Welcome, everybody, and welcome to our Prostate Cancer Survivorship series. I'm Dr. Michael Lutz, and I'd like to welcome all of you to this evening's event. We're actually really excited to do this. Our foundation actually started way back in 2008, and we're very proud to be celebrating our 15th year. Our Prostate Cancer Survivorship series and support groups have been around for quite a while, dating back into the 1980s when the American Cancer Society first formed the Man-to-Man Prostate Cancer Support Group. Things have morphed since then, understanding that it was more than a survivorship for an individual. It was a survivorship for the family and their friends and their relatives and all of the people that are involved in their family. And therefore, Us Too was developed in the late 1980s. And here in the state of Michigan, we were the first Us Too prostate cancer support group. Since then, our prostate cancer survivorship series has developed and expanded, and it went from an in-person event to a remote event as a result of the pandemic. And we've maintained that format over that time so that people can actually experience this event in the comfort of their own homes, as well as in the privacy of their own homes. And if you wish to see other prostate cancer survivorship event series that are part of ours, you can go to our YouTube channel and visit the rest of them. Tonight's event has been organized and developed by our executive director, Dr. Andrea Hamilton. I already made her a doctor. And this event was actually designed specifically to advance the knowledge and the application of this imaging modality that we'll be talking about tonight. Tonight, our topic is all about advances in diagnostics, and we're going to be talking with people in our prostate cancer caring community. One of our guests, our first one is Mark. He's a prostate cancer survivor and a Blue Earth Diagnostics patient engager. He's being compensated as a consultant by Blue Earth Diagnostics. Our other guest is Dr. Alain Chaglassian. He's the medical director and employed by Blue Earth Diagnostics. And lastly, but not least, is Dr. Thomas Boike. He is a board member at our MIU Men's Health Foundation, and he's also the United States Chief Medical Officer for Theranostics for Genesiscare Network. Mark, just curious, I just want to start out to ask you, why did you choose to become a prostate cancer advocate?
Well, it started when I was first diagnosed with prostate cancer and working with an organization called Zero Prostate Cancer, and seeing the kind of work they did. And, anybody that gets that diagnosis with cancer, it's a shock to the system at first. And then after it settles in and you go through the various therapies, you realize that there's a lot of people working very, very hard to make things better for prostate cancer patients. And I saw it as an opportunity to contribute.
Thank you so much. And Dr. Chaglassian, it says you're the medical director. What is the role of a medical director in an organization like Blue Earth Diagnostics?
Well, it's many different functions. I run the investigator-initiated trial program, the research program at the organization. I have cross-functional work I do with the marketing, commercial, sales team as well. I provide presentations that are medical and scientific in nature across the country based on our data and many more things. So quite a diverse role I have at the company at the moment.
Thank you very much. And Dr. Boike, the United States Chief Medical Officer for Theranostics. Theranostics is quite the word. Can you kind of explain briefly what Theranostics means?
Yeah, so this is a very new, exciting type of precision medicine for patients. And it's really kind of gained a foothold in prostate cancer based on PSMA. PSMA is, expressed on prostate cancer cells and can be targeted very specifically. So Theranostics is about imaging to identify a biomarker or a target, and then treatment to then target that biomarker or target. And it's, very exciting precision medicine, which is what we want,
Well, thank you so much. I'd like to again welcome our guests and thank you all of you for being here. I'd like to remind everybody who's watching this series and is a part of our evening tonight that the information we'll be sharing is provided primarily for educational purposes and is not intended for medical advice. If you are looking for medical or treatment related questions, please talk with your healthcare team. And although tonight's event is principally being sponsored by Blue Earth Diagnostics, we will absolutely be recognizing and acknowledging all of our other relevant sponsors and partners who support all of our foundational aspirations. And those supporters this evening are Lantheus, the American Cancer Society, Blue Earth Diagnostics, Boston Scientific, Neoking Physical Therapy, and of course, if we're going to stay fit through all of this, Planet Fitness. I'd like to start our discussion with Mark. Can you tell us a little bit about yourself and why you're here this evening?
Sure. I'm getting close to my 66th birthday now, just shy of 66. I live in Maryland with my wife, Kathy. 2 grown children they're out of the house. I am a 30-year veteran of the United States Army, retired in 2012. And I currently lead the History and Legacy Branch for the United States of America Vietnam War Commemoration. This is a DoD office that has been tasked with thanking and honoring our Vietnam War veterans and their families for their service and sacrifice and giving them a welcome home that they didn't get 50 years ago. And but I am looking to retire them in the next year or so. And when I talk a little bit more about my prostate cancer experience, that had a lot to do with why I got involved both with Blue Earth and other organizations.
Well, I know we spoke earlier before we went live, and I want to take one moment to say one thing for sure is thank you for your service.
Well, thank you. Thank you very much.
So I appreciate what you've shared so far. Can you kind of tell us a little bit about your experience with your diagnosis of your prostate cancer and what you've experienced since the diagnosis?
So every year when you're in the military, you get an annual physical exam. And I was 54 years old in 2011 during an annual physical. And the physician's assistant noticed that my PSAs, while they were within normal range, she compared them to previous physical exams and noticed that there was a dramatic increase in the levels of the PSA, even though they were within normal range. And she recommended a biopsy. So in March 7th of 2011, I had a biopsy, and then on March 14th of that, a week later, the urologist called and said, Mark, we need to talk. Biopsy came back, and you do, in fact, have prostate cancer. You have a Gleason score of 7. So we talked about different options. I went up to the old Walter Reed, the Army Medical Center, where they had a great round robin kind of day where you talk to the radiation oncologist and other doctors. And I decided that surgery was my best option. So I had a radical prostatectomy in May of 2011. A couple of months later, I got the pathology report that the prostate had been examined and was negative at the margins. So I assumed I was good to go and everything was good. And it was for about 10 years. And then during another routine exam, the doctor noticed that my PSAs were not just detectable, but at a fairly high level. I think they're around 0.5. And if you don't have a prostate, you shouldn't have a PSA of 0.5. So he recommended some imaging to see just what was going on. And sure enough, I went and had the imaging, and it determined that I had a biochemical recurrence of prostate cancer. They saw hot spots both in the prostate bed and in the lymph nodes. And then the other thing they noticed is that there were some hot spots around the colorectal area. So they recommended a colonoscopy. And lo and behold, after the colonoscopy, they confirmed that I also had colon cancer. So this presented the doctors with a bit of a challenge, and that they had to treat 2 separate cancers simultaneously. But I am happy to report that after 39 radiation treatments to treat both the colon cancer and the prostate cancer, 9 months of hormone therapy, 8 cycles of chemo over 16 weeks, and 2 surgeries, the prostate cancer is in remission and the tumor from the colon is gone. So very, very grateful for everything that they did.
Thank you so much for sharing. I want to go back to the beginning when you were diagnosed.
Sure.
You know, I can tell you from my own experience, having made that call several thousand times since I initiated my practice in 1986, that is absolutely the most challenging part of what I do. And I can only imagine on the other end receiving that phone call, because I have received phone calls like that for myself. And I know that when you get that phone call, you never forget where you were and what that moment was. But my question to you is what was your family conversation like? Not many of us share this discussion, but what was it like when you had to share it with your spouse or your children or other family members?
You know, that's a great question. I think it was harder on Kathy than it was on me. I mean, I got the diagnosis, and in the military, you kind of mission oriented and you realize, okay, here's the problem. Here's how we're going to solve it. Just carry on. Kathy was scared. And I think I think it really affected her more than me. But then she became the mother hen, and I got to tell you, it was more care than at times probably than I needed. But she was incredibly supportive after she got over the shock and the fear and realized that, okay, we're going to go through this. It'll be fine. And the same thing when I got the biochemical recurrence. So I've got nothing but great things. My family was supportive. I've had great bosses at work. They were incredibly supportive. So I had a lot of tremendous support. And then, of course, I'm very, very grateful for everything that the physicians were able to do. But yeah, good question. It was really, I think, tougher on her than it was on me.
I like when you said more care than I thought I needed. That is a very guy response, because
Yes.
as guys, we really don't think we need much attention, but you really want it. It's kind of like you want to push it away, but you really need it. Do you feel like you went through much anxiety or depression from the time of the diagnosis to and through your initial parts of treatment?
Initially, more shock, but I never said why me. I don't recall ever saying why me, because I figured, well, why not me? So many other folks are diagnosed with cancer, and it's just, it's an ugly thing, but I'm grateful that there are therapies now and treatments available that are able to extend or cure. So I guess once I got over the shock again, it was more kind of this is the mission, this is what I have to do. And I didn't wallow in too much. To say I was depressed, maybe I might have had a day or two where I was kind of like, but for the most part, no, I don't think I ever thought that way.
Got it. Any treatment regret?
Treatment consequences, but
Okay.
I figure that's just part of that just comes with the territory. So, with the radiation, there is a certain amount, there's incontinence and there's impotence, and that's the big elephant in the room that guys don't like to talk about a lot of the time. But there are there are ways to cope with that. And the chemotherapy has left me with some neuropathy in the feet and in but nothing that it's all manageable. Everything's manageable, and I'm still 6'1" in vertical. So I'm grateful.
Well, thanks for sharing. Appreciate it. I think it's time to bring Dr. Alain Chaglassian into the conversation. Dr. Chaglassian, Mark mentioned about imaging and how it was an important part of his diagnostic and becoming his therapeutic journey. Can you please talk a little bit about what are some of the technology options for diagnosing and treating individuals who have prostate cancer and/or recurrent disease?
Sure, it is quite important. I'm sure Dr. Boike and others will attest to this as well. There's several types of imaging agents that are used to diagnose and treat both primary prostate cancer and recurrent prostate cancer when it comes back. You have imaging things like transrectal ultrasound, CTs, MRIs, bone scans that all have different sort of capabilities within both of these settings. They're really utilized to find out more information about the prostate tumor itself, the spread outside the prostate or any metastatic disease, and potentially whether the prostate cancer itself has spread to the bones, which is where progression is really likely to be found. An injected diagnostic imaging agent, which we call in our industry a radiotracer or a radiopharmaceutical, could be used together with either a PET CT or a PET MRI scanner to really provide more information than some of the previously mentioned imaging techniques that I just went through as well.
I'd like to actually bring Dr. Boike in just for a moment here. Tom, there was this reference that Mark made earlier about his rising PSA. Can you kind of comment a little bit about the difference of when a man is diagnosed with prostate cancer, what his PSA level is at the time of diagnosis versus a PSA from recurrent disease if they were previously treated with surgery or radiation, and how that might be different, and then how we would apply some of this advanced PSMA imaging technology apropos to that rising PSA?
Yeah, so that's a great question, and I'm sure Mark will attest, one that we like to have patients very aware of what their PSA should be, right? So know your number. And kind of in the early stage when you're under screening and your primary care is checking it, we like to see that number below 4. And I think, there's different ways to figure out if that number creeps up around 4, should we do a biopsy or not do a biopsy? And then imaging comes later based on several clinical factors that we might find in the early diagnosed stage. But after men have treatment, the PSA is quite different. So if men undergo surgery, we like to see the PSA go below 0.2, hopefully to undetectable. And, this is a weird kind of misnomer where undetectable is 0. The labs kind of report it as it's lower than the resolution of the test. So we call it undetectable, or we call it 0, and is what we like to see after surgery. Now with that, after radiation, it's a little bit trickier, where we tell patients your PSA is going to decline over some period of time, usually months to maybe even a year if it's a slow growing cancer. And we like to see that PSA go down to less than 1, maybe around 0.5. I'd be happy if it went to 0.2, but never go up again. So men will know what their nadir is or what their lowest point is after radiation. And then we continue to check them, every 3 months for the first year, every 6 months, we make sure that PSA stays low. If the PSA starts to go back up, and this was originally where PSA was FDA approved, it wasn't approved for screening, it was approved for monitoring after therapy because it is such a good way to monitor. But if that PSA goes up and goes up even slightly, then we consider advanced imaging. Nowadays, if you look at the guidelines, and I'm thankful that all these guidelines have been updated very fast. So you have guidelines from the American Urological Association or the AUA, from the Society of Nuclear Medicine, and from the NCCN, which is the National Comprehensive Cancer Network, which really are kind of moving towards this molecular imaging or PSMA PET imaging in the biochemical recurrence setting. Now there's different yields for this PSMA imaging when your PSA is low in this biochemical recurrent or PSA recurrence after therapy. But even for someone with a PSA of less than 5, about 30% of the time we can see where that PSA is coming from. And that really changes treatment. And the other thing to note is when the PSMA PET is negative, it doesn't mean that someone doesn't need treatment if their PSA is coming up after surgery, but it is a sign that they'll actually respond to treatment better. So even getting a negative scan in that setting is helpful for patients, for their families, to put them at ease.
So just to clarify, you meant a PSA below 0.5.
Oh yeah, sorry, 0.5. That's what I meant. Yeah. Please, thank you.
Because it's interesting. Talking about the lowest level of PSA to diagnose prostate cancer is a real challenge, and I think we'll talk to Dr. Chaglassian about that a little bit. There's been a lot of excitement about Posluma as well as other reagents, and I thought I'd like you to explain what it is, how the technology differs from the other imaging modalities, and have you kind of explain to you where we're heading.
Great, thank you. So I just wanted to go over the indication. First, a Posluma injection is indicated for PET of PSMA positive lesions in men with prostate cancer with suspected metastasis who are candidates for initial definitive therapy and with suspected recurrence based on elevated serum PSA levels. Next slide, please. So just to review the important safety information, image interpretation errors can occur with Posluma PET. A negative image does not rule out the presence of prostate cancer, and a positive image does not confirm its presence. The performance of Posluma in both the primary and recurrent prostate cancer setting is affected by serum PSA levels, and the uptake of the scan isn't specific for prostate cancer. It can be in both malignant and benign lesions and normal tissues. The interpretation of the scan could depend on the reader of the image, particularly in the prostate bed area, so consider multidisciplinary consultation in histopath confirmation as well. The use of Posluma does contribute to patients' overall long-term cumulative radiation exposure, but it's pretty much less than having a CT with contrast. Next slide, please. And adverse reactions were reported in greater than or equal to 0.4% of patients in clinical studies. And these include common things like diarrhea, blood pressure increase, and injection site pain. And for patients on ADT therapy, the uptake of Posluma could be affected, but their effect on the performance of Posluma hasn't been established. And to report suspected adverse reactions, you can please contact the FDA as seen here. Thank you.
Thank you so much.
Good.
So I just, again, think it's important to reiterate how low a PSA can be to detect disease. Before PSMA PET CT scanning came around, we used to call it oligometastatic disease when somebody's PSA would start to rise. And the reason we use that term is because we couldn't see it. And with all the previous types of imaging modalities, bone scan and CAT scan technology, they were just inadequate for detecting recurrent prostate cancer with those very low levels of PSA. So now we have the ability with these PSMA PET reagents to actually detect prostate cancer in ranges before that were known as undetectable or oligometastatic disease. So can you comment a little bit about the advantages and how low some of the PSA levels can be for these tests to be positive and detect disease?
Yeah, I have a rule of thumb when I talk to patients about this, because a lot of patients want to know when you're ordering a test, how you're going to use it, what's its likelihood or pre-test probability of being positive. But I think when you look at these PSMA agents now, if the PSA is less than 0.5, you have about a 30% chance of detecting something, give or take. If the PSA is about 0.5 to 1, it's about 50%. If it's 1 to 2, you're up in the, maybe 70, 80% range. So as the PSA goes up, your likelihood of finding where it's coming from and directing therapy based on that, or tailoring therapy, really goes up. Now, and like you said, Dr. Lutz, when you're looking at the agents or the imaging studies that we used to have, bone scans, CT scans, which are good and we use for many cancers, a PSA of 2, you're not finding anything. Like it's the detection rate is around 0. So 80% of the time with a PSMA PET, you're finding something around, a PSA of 2. Conventional imaging or bone scan CT, very, very, very low.
So Dr. Chaglassian, did you want to comment a little bit about the Spotlight trial with regards to recurrent prostate cancer and how this was applied?
Sure. So the Spotlight trial was for patients with recurrent prostate cancer. We also had patients in the Lighthouse study that was for primary prostate cancer as well. In the Spotlight study, the detection rate or the percentage of patients who had a positive scan within the total overall patient population was 83%. At low PSA levels, less than 0.5, where you really want to spot disease most early on in recurrence, the detection rate for that study was 64% as well.
Which is incredible. Did you want to talk a little bit about the risks associated with these PSMA PET reagents?
So in general, they're very safe compounds. We had very minor adverse reactions in our trials. And I think that's something that's very good for the future. They're very, very safe compounds, these radio tracers as well.
And do you have what type of patient do you think will benefit from this kind of a study?
Sure, I could share a brief patient story with you. This patient was a 58-year-old man who had high-risk prostate cancer, and the pathology showed us that the tumor had spread beyond the prostate. The patient had surgery to remove his prostate, but his PSA level never went to 0, meaning he still had active disease somewhere in his body. He subsequently had a Posluma scan that showed disease in his pelvic lymph nodes and lymph nodes outside the pelvic area. And this could allow a treating clinician the ability to provide a patient with appropriate therapy moving forward.
So what is your perspective on the potential impact of this kind of imaging for the prostate cancer community?
We really do think that Posluma has the potential to benefit patients as really an important diagnostic tool, because it really does offer more actionable clinical information than conventional scanning options we mentioned, CT, MRI, bone scan. Accurate imaging techniques are really critical for clinical decision-making. And as observed in our clinical studies, physicians often decide to change the patient's treatment plan based on the Posluma scan itself. Out of the patients for whom sufficient information was available to review for changes in treatment, so management change in our trials, 89% of patients had a change in intended treatment. And of those patients, 91% had a major change in treatment and 9% had a minor change in treatment. So this is very critical for these patients moving forward, the change in management data that we've gathered and that we continue to gather as well.
Well, in my world, PSA, when I first went into practice, was the biggest game changer. And I can tell you that as I'm now about to exit practice of medicine, PSMA PET CT imaging is now the biggest game changer in the diagnosis and management, follow-up care of our prostate cancer patients. So thank you for your help and your advice tonight. Dr. Boike, a couple of questions. You know, the National Health Service, which is the authorization organization in Europe and the UK and other countries, have adopted PSMA PET imaging for the staging at initial diagnosis of prostate cancer. But here in the US, we're lagging behind, and it's not approved at this point in time for the initial diagnosis, or maybe it is, and I'm just having trouble getting it. But it's one of those things, like, how can we make this a standard of care? And what do you think is the role of standard of care for this technology for patients with newly diagnosed prostate cancer? Should all patients with prostate cancer newly diagnosed get PSMA PET CT imaging, or should it be used for different stage or grade disease at the time of diagnosis?
Yeah, so this is a great question, and like you said, we're kind of lagging a little bit in the US. So the first PSMA agent in the US that was FDA approved was actually FDA approved in May of 2021. So it was during COVID, and maybe it had a slow uptake. You know, we started using it then. The guidelines came out quite quickly afterwards, where the National Comprehensive Cancer Network, the Society of Nuclear Medicine, they went through these use cases that really drill down to what stages would benefit most. And it's based on the clinical trials that we've been discussing. So when you have a patient, based on the FDA indication, when you have a patient that you're suspecting for metastasis with higher risk disease, so an elevated Gleason score, an elevated grade group, a PSA, over 20, those are higher risk patients, and they should undergo PSMA PET. And that's what the guidelines say. In the US, we have prior authorization and we have hoops that we need to jump through. But, those are coming around. Everything new, requires that. Really, the difficult one to tease out at first diagnosis are these patients that have unfavorable intermediate risk. So just to back up a little bit, when we talk about prostate cancer at diagnosis, there's lower risk, there's intermediate risk, and then there's high risk. High risk is getting PSMA PET. But in this era of intermediate risk, or this range, sometimes you're a little bit closer to high, sometimes you're a little bit closer to low. And if you're a little bit closer to high, or what we call unfavorable intermediate risk, and there's several factors that can put you there, those patients are recommended to get PSMA PET too. But it requires very specific documentation by the physician in order to get that prior authorization for that.
Thank you for your input. Thanks for your help. I'd like to actually go back to Mark, who's been listening into all of this, and I'd like to kind of get your reaction to Posluma and the role of PSMA PET imaging. And based on your experiences, your conversations you've had with other individuals who are prostate cancer survivors, how do you think having this other imaging option is going to help our prostate cancer caring community?
Well, in my case, the imaging provided the radiation oncologist a place where a more targeted kind of application of the radiation therapy. So he was able to see where to go and know where to go. And it's just another tool in the kit bag of the doctors that they can use. I think it's really, really important. It gives the patient more options. It gives the doctors more options. And the overall goal is to improve care and treatment of the patient. And I think that's what this does.
Yeah. Well, thank you. And thank you for being here and helping us out this evening and helping those who are listening in and watching right now. I'd like to go back to Dr. Boike for a moment. Dr. Chaglassian had talked about various types of imaging used to diagnose and stage prostate cancer, whether it be upfront at the time of diagnosis and staging, or for those with rising PSAs post-treatment with the concern of recurrent disease. Can you kind of walk us through your experience with PSMA PET imaging and where you think we're going and how Theranostics might actually play a role in using this to treat prostate cancer?
Yeah, and I think you hit the nail on the head, that this is a a game changer, right? It's really changing the data that we know about, the trials that we've done in the past. We're having to interpret things through a new lens, which is this PSMA PET, where we're coming up with new ways to study it. But if you look at, a rising PSA after treatment, and you're getting a PSMA PET and you can see the disease, that may be something that's located right where the prostate was. And so it's confirming your treatment of radiation to that area if the patient had surgery. If patient had radiation and their PSMA PET is only positive in the prostate, we're starting to do more salvage options. So the urologists are doing cryotherapy or freezing the gland. There's some reirradiation options, but it helps get that PSA back down. And then you can delay things like hormonal therapy that are used to treat the whole body. In fact, as you've mentioned this term, oligometastatic disease, we're starting to see those patients with maybe 1 to 3 spots on PSMA PET, and we're starting to focally treat those spots and delay things like hormonal therapy that has a big effect in quality of life for these men. But as things become more advanced with PSMA PET, you're detecting multiple lesions. You have lots of options for treatment. We mentioned genetic testing and the role for PARP inhibitors, as we were talking, getting ready for this. You have the hormonal therapy agents, chemotherapy. And now, as you get after chemotherapy, there was a trial done called the VISION trial that was published in the New England Journal of Medicine. And this medication is getting more and more active. So you can do PSMA injections that are not only diagnostic, in the case of PSMA PET, but therapeutic. And what they do for that is where that PSMA medication sticks to the prostate cancer, for the PET agents or the imaging agents, it kind of glows like a light bulb, and we can see it on the scans. But where that then sticks, it delivers like a bowling ball when it's the therapeutic medication. Pluvicto is the FDA approved one right now from Novartis, but we have lots of trials coming. This is an extremely active area of research. And it's offering real hope for men after things like chemotherapy where it's FDA approved. We're seeing responses in men that have had a significant amount of therapy where their PSA is declining over 50%, about 70% of the time. And they're having what they call exceptional responders, where the PSA is declining over 80%, about 20% of the time. So in these men who have gone through a lot of treatment, this is a very active, promising medication. And the questions for a study right now is, should we move it earlier? And can we do things like have a true pair where it's the same molecule, like in the case of Posluma, where you could maybe have an imaging agent like fluorine or F18 that glows like a light bulb, and then swap out that fluorine for something like lutetium or actinium, we're investigating a lot, and it bind to the same portion of the PSMA molecule or receptor. And so I think this is, again, a really exciting, lots to do, and I thank every day all of my patients for participating in research like this. I know we're quite active at MIU. We're active in my practice with these clinical trials.
Yeah, this is one time where a plug for clinical trials and research trials are really so important for patients to participate in, because it's the research that actually will give the improved care, not only for you, but for those that are to follow you. And prostate cancer being such a slow growing disease, and in most cases, men, well over 90% will die with it rather than from it. It makes it even more difficult in general to see the success rates of a lot of these clinical trials. Thank God that it is not a death sentence in the majority of cases, but more of a life sentence. And what Dr. Boike is actually talking about is taking a diagnostic imaging test, such as a PSMA PET scan, and making it a therapeutic treatment option as well, where it can actually exactly target the cells that need to be treated by using a radioactive compound to be mated to the diagnostic PSMA reagent. This is absolutely the biggest game changer in prostate cancer therapeutics. And the thought is, if we can do it sooner versus later, we would treat lower volume disease with lower toxicity and lower complications to the patients. And I think that's really what he's actually alluding to. And hopefully the NCCN guidelines will identify this, and the clinical trials will proceed, as we are already starting to take part in, to apply these newer technologies in Theranostics that Dr. Boike is so well experienced in, that we can actually make these applications and see the fruits of this kind of treatment come true and lessen the toxicities of recurrent treatment of prostate cancer, so that rather than throwing, giant bowling balls at patients, we can actually target these with the very small focused areas and actually treat the disease without the complications. Do you want to talk a little bit about what are some of the side effects of PSMA PET imaging and with the therapeutics?
Yeah. So, what we saw with Posluma, as well as other agents like Pylarify and the gallium agents, is that the side effects of imaging are very low. And one thing, that's been mentioned, but is probably worth repeating, is that they're so low, lower than things like even a contrasted CT scan as far as radiation exposure, but also exposure to the dye. So things like PSMA PET imaging, they don't really have a contraindication for kidney function. Whereas contrasted CT scan, you have a limitation for kidney function. So these are very safe imaging agents and very specific. When you get to the PSMA therapy, it's a very targeted therapy, but nothing's without side effects, unfortunately. So I always plug for research, and I appreciate your plug for research, because really the goal is to have a treatment that's 100% effective with zero side effects. I wish I could be touting something like that, but I'm thankful that we're getting low in these PSMA therapies, where the side effects may be something like tiredness, maybe a little bit of dry mouth. That dry mouth can lead to nausea or change in taste. And when the cancer is located in the bone marrow or the bones, sometimes we can see anemia or thrombocytopenia, which is a lowering of the blood counts, along with these medications as well.
Your presence is more than helpful in answering a lot of these questions that we would not be able to answer without you. And I think it's really great. I mean, it's important for people to ask questions. It's important for people to understand that there are research options out there, and that technologies are being developed at an incredibly rapid pace. We're advancing out of a straight hormonal therapy. There are medications now where, as you talked about, immune checkpoint inhibitors. And we maybe our Dendrion product, which is Provenge, will come back again to another strength, because it will be very easy to monitor its progress looking at PSMA PET scans. And maybe it'll have another role in the management of diffuse recurrent disease in people who have been primarily treated and have unfortunately not done well with local curative therapy. So looking at all of these additional treatment options, I think that it's going to be great looking to the future over the next 5 to 10 years.
Yeah, certainly. As a new medication comes along, the things you think about studying is things like biomarkers. So can we identify people who are going to be those exceptional responders and give it to them earlier? We're getting some great information from PSMA PET from the imaging, where if their total SUV, or the uptake, the amount of PSMA that's sticking to the cancer, is high, or if it's above 10, this number of 10, that those people are going to be better responders. It doesn't mean that the other people don't respond, but we're starting to tease out who responds better. We're starting to, as you said, and we've talked about, tailor therapy and add in external beam radiation or ablative therapies for oligometastatic disease. We're truly learning something every day, because these new systemic therapies, can you give them in combination with things like androgen deprivation therapy? We had a trial that's accrued in men with newly diagnosed disease that spread to the bones, and it's moved all the way. Pluvicto is moved up in that trial alongside standard androgen deprivation therapy or hormone treatment. can you give it instead? You know, that's what everybody's asking. The patients want to know if it can be given instead. We're working to get there. You know, we're trying to study hard.
Well, I think you've actually dovetailed into one of the topics that I look forward to covering, which is the genetics of prostate cancer, because there's really two types that we need to look at. One is the actual tumor genetics, and the other is the actual somatic or body genetics of the individual who's harboring the prostate cancer, so that we can approach both of those looking at the idealized treatment option for that patient. So I just want to thank our three guests this evening for being here. This was a really great night. Talking about PSMA PET scanning gets me really excited because it is truly the biggest advance. And Mark is a great example. He's just such a great storyteller about what it is and how it actually saved his life, identifying the recurrent disease so he could be treated most accurately and with the least amount of side effects and complications. And Dr. Boike showing us the direction of where we're going to be within the next few years. I'm excited to watch it and to see how it'll help our prostate cancer community, and Dr. Chaglassian for being a part of Blue Earth Diagnostics and sharing their message, as well as all the other companies and all of our sponsors, Lantheus, American Cancer Society, Blue Earth, who's here tonight, and as well Neil King, Physical Therapy, and Boston Scientific, and lastly, of course, Planet Fitness, for keeping us strong and keeping us well and doing what we need to do all the right things. I want to thank everybody for being here. On September 30th is our upcoming men's health event. It'll be held at Ford Field. We are excited to have this event. You know, men's health is mental health. And I kind of dovetailed that a little bit in my conversation with Mark about the associated anxiety, depression that is known to be with prostate cancer diagnosis and management, particularly men on active surveillance. So acknowledging that mental health is an issue, and we know that there is quite a bit going on right now in our community. We are addressing that as one of our primary discussions in our upcoming men's health event this year at Ford Field. We will have more than enough services available for everybody who attends this event to have this as part of their services at the event, in addition to all of the other services that we do provide, all for free at Ford Field from 9 a.m. to 3 p.m. on Saturday, September 30th. So if you have a chance, come join us at Ford Field. Tap me on my shoulder, let me know you're there. I'm certain Dr. Boike and others will be there to join us. He's always one of our physician experts for Ask the Healthcare Provider. And we'll also have a halftime show at noon where we'll talk to some of our leading experts talking about disparities in prostate cancer survivorship. And we really look forward to have a great event. Thank you for joining us this evening. And